So let's take up one case that which is a short case, which is Potter only, where we provided you with a lesion on the back, which was a nevus that had undergone a change. I'm so glad everybody answered beautifully, and the amongst the better answers we have Manya, we have Naveen answering very well, almost completely. Now this is to be taken as malignant nevus if it changes color or starts itching, starts discharging, starts expanding. All these features should be suspicious of a carcinoma, a melanoma, and usually it is not directly a factor of ultraviolet rays, but a nevus is a factor, and junctional nevus is more likely to be a case. So when you are looking for, it was in the back actually, it started discharging, it's become itchy. The idea was to make you realize that you'll treat it as a melanoma unless proven otherwise. And rightly said, most people answered correctly. An edge biopsy with depth should be taken down to the fascia, and we must make a point that we should take a biopsy from an area that can be covered in the incision later on when you're doing. See, I'll show it now. Take an edge biopsy, but don't expand it beyond a point. Now the depth is for the Breslow staging and also the staging for malignant melanoma, which I will not discuss here because it was a very short spotter for all of you to understand as to what should be done. And what did we do? We then, after incisional biopsy, we got a diagnosis of malignant melanoma along with immunohistochemistry, and we knew the depth, which I am not discussing here. So patient was taken up for surgery, which can be a wide local excision. This was the lesion. So wide local excision could mean about 2 centimeters all around. Some books say 1 to 1.5 centimeter, but importantly it's the depth. And you should always have the length more towards the lymphatic drainage site. And you should also look for certain, here I didn't mention, must look for satellite nodules and also in transit nodules. The in transit nodules are actually along the spread. When the spread happens, I think I'll take that, lymphatic, hematogenous, and of course direct, deep. Lymphatic is usually by either embolic method or permeation. Permeation is where it grows along the lymphatics like a snake. So this is when you can actually get the in-transit nodules, and they should be looked for, and they'll depend on the drainage area. So we should examine the inguinal lymph nodes carefully, both sides, and exclude in-transit nodules. Then hematogenous will of course involve getting the X-ray chest, ultrasound abdomen. Some people say you get a CT, the guidelines for it. And if it's an early lesion, it may not be present. I mean, ultrasound is for liver, so you look for liver, lungs, brain, bones, and find out the metastasis if you can, because accordingly you will decide whether the patient needs surgery first or chemotherapy first. And we have heard of DTIC and various chemotherapeutic regimes in malignant melanoma. Now in this case, this was the lesion. We had an option to actually go wide and put a flap, but we use what is called a Limberg flap here. The picture will be provided to you, which is based on the 60-degree rhomboid. So some people also call it a rhomboid flap. And what do? We normally find out the margin. This is the midpoint, and this was about 4 centimeters here, and we took the 4 centimeters here and another 4 centimeters here beyond the margin. And then all angles are 60 degrees. So we can take it here, we can take it here. We took it here 60 degree, which is parallel to this. Now once we I'll draw it again so that you can understand it better. First, the concept of Limberg flap, very commonly done in pilonidal sinus. Suppose this is 4 centimeter, this is 4, 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 and this is also 4. We draw either side, we can take it. We make it 4 centimeter here, and then we draw a parallel line to this, right? And this is a straight line here, you don't go there. But the lesion is excised, so we are left with a defect which is like this, while this is intact. Now this is mobilized X, which should fit in here. This gets straightened therefore, and in the process this would be moved up. So what do we achieve? This X will fit in here and it will automatically get closed. That's a Limberg flap. This is, it falls in a straight line and we close this defect. That's a rhomboid flap. But the important thing is that angle is 60 degrees all around. That makes it easier, 60. And actually it moves like this. Y comes here, X goes here. So X comes here, Y comes here. So it moves in a manner like this, and this kind of gets straightened, and the picture would explain it also. That's how it was managed using a rhomboid flap, because it's a rhomboid, you made it. Patient will be subjected to chemotherapy now. All margins are R0. You should check it in the by frozen section, or you can get a final histology, and then the patient is treated by chemotherapy if the pathology indicates this. Importantly, we need to know the depth. Depth is very important in melanomas. So I thought I'll cover up just two cases together so that you are able to retain more, and all queries are welcome. Most of you answered very well. I must compliment you, and I must share with you that a lot of answers given by undergraduates were at par with the postgraduates. And I can't name all, but yes, Naveen, Rishabh, Manya, then the Cheshta answer, which is probably will be discussed in the next scenario related to the barium swallow. But most of the answers were very good, and I'm extremely happy. I hope you enjoy it as much as I enjoy getting it to you. Thank you very much.